Fortunately, this is always an exciting topic for everybody to discuss, but an important one, which is compliance and appropriate documentation for visits. So E&M stands for Evaluation and Management, as you see in the title, and Brenda has given this talk year after year, primarily to remind us and then teach the trainees kind of all the elements that are important, what we're missing, and what we can do better on. So it's going to be Brenda along with Amy Ardiana as backup, and then Brigida is somewhere on this grid of people. And Brigida Larson will also talk. She's the one that's spoken to us before about templates for discharge summaries and other documentation to try and make sure we don't miss out on things. So Brenda, thank you very much for taking the time and appreciate it.
Thank you. Good morning, everybody. I actually am excited to share this information because hopefully it will make documentation easier. So it's a little bit different and new compared to what we've talked about over the last several years. I'm bringing up my PowerPoint here. We're going to share the PowerPoint as well, but there are some significant changes that are happening beginning in January. If you have questions, Brigida is going to facilitate the questions in the chat room. So be sure to type your questions in and we can make sure we get those answered, and we can always follow up with an FAQ document as well. So the changes that are happening are really occurring because of the electronic record. Your average progress note has tripled in the last decade. And most of you spend your time in the notes and letters sections of the electronic record. So the AMA, along with CMS Medicare, have updated the guidelines. We are starting with the group of codes for new patients and established patients. And these changes are occurring to help simplify the code selection. So that will help the coding team. Reduce repetitive clinical documentation, and also to help reduce clinician burnout. So again, these are going to affect your new and established patient office visits. It is the largest change that has happened in these guidelines in the past 25 years, and these will go into effect beginning in January. The first thing that we wanted to share is that they will be deleting the level 1 new patient visit. We did pull our data from UW Health, which mirrors national data, that it's the least utilized code in the code set. So beginning in January, we'll have 4 new patient visits that the coders will choose, or 5 established levels of service for established. The way that the coders are coding for you right now is based off of 2 ways of coding. It's your history, exam, and decision making. Which over the last many years, we've come and shared how to document the review systems and your various other elements in the notes so that we can bill accurately for you based on your documentation, or the time spent counseling and coordinating care, which the requirement now is greater than 50% has to be spent in counseling. And when you document your time, the coders are required to use your time to bill the level of service. The change for 2021 for these code sets is we'll be coding based on your medical decision making. And the coders now have a new table that they'll be using with some definition changes that we wanted to share so we can clearly have everything documented and added up or scored, if you will, towards that level of service, or total time spent on the patient's encounter date. And the level of service now can be chosen on either or. So the coders will look at both time, if you have that documented, and the medical decision making, and pick the level based on the higher or more complex documentation, or the time, whichever gets you to the highest level. So these are all the building blocks. I like this visual because it shows what is going to go away for scoring. So what the AMA has done is eliminated the requirements for the history and exam for choosing the level of service, and will focus specifically on your medical decision making. Those elements are important, but are not required, and we don't need to count those any longer for the new and established patient visits. The other option for billing is on time. This is going to be a change in the definition. and it's time spent on the day of the encounter. So what's nice about this is it's now including non-face-to-face time associated with the visit. So anything you do before the visit, during the visit, or after the visit are going to be counted, and what needs to be documented is the total number of minutes. It does have to occur on the same calendar date that was clarified by the AMA, but any of that work prior to midnight, we can count those minutes. So what they've eliminated is the counseling and coordination of care has to dominate the visit. That greater than 50% is no longer required. They did adjust time ranges. The coders have been trained and educated, and they actually have been using this a bit with your video visits. Currently, they're using our specific time, the specific times that are associated with each code. For example, a follow-up level 4 visit is 25 minutes, etc. Now we have time ranges, but I did want to show you that there is a shift down in 2 of the codes. The level 4 and the level 3 are shifting down 1 level with these time range adjustments. So we just wanted to point that out, that change will occur in January. They have also added a prolonged service code, which I'll show you in a couple minutes how that code will work for your longer visits. We also wanted to share with you all of the things that could be counted if you perform them on the same date of the encounter when we bill based on time. So it's a pretty extensive list. Preparing to see the patient, obtaining your history, performing your exam, counseling, ordering medications, tests, or any kind of procedures, communicating with other healthcare professionals. And the biggest change we saw, in addition to these items, is you now are allowed to count for your clinical documentation time. So one of the things that the AMA wanted to address was your documentation time, or your PJ time as they call it, of all that time you're spending documenting in the record. Those minutes can be counted now if it's performed on the day of the encounter. We can also add any interpreting of test results, care coordination, really things that we're not billing a separate CPT billing code for. We are working on some dot phrases. These are actually being finalized this week. This is just a draft of what it will potentially look like. It just says I spent a total number of, and then you fill in your minutes performing those various activities from the previous screen. We're going to offer a pick list for you, but that then should suffice the actual documentation requirement for time. We also are working on one for procedures. Carve-outs doesn't apply to your specialty, but procedures where we would just have to exclude any procedure time for a procedure that might be done on the same day as an E&M visit. And then decision making. I know the coders are coding all of these services for you, but we wanted to just share what those definition changes are so that we can enhance the documentation to meet these requirements. So there's 3 elements to the medical decision making. The number and complexity of problems addressed. Currently, the rule is, or the way that we look at your diagnoses is whether they're new or established, and that those definitions have been deleted. It now addresses any problems that you're addressing during the encounter. So the documentation just needs to be clear about the problems addressed during the encounter, the relevance to that. The message is a blown-in problem list in and of itself without any further assessment or relevance would not count. So anything that you would address on a problem list, it certainly would be counted, but just listing them in a problem list wouldn't count in and of itself. The second piece of decision making that the coders are looking at is the amount of data that you review, and then they added the definition and analyzed. So the message here is just copying and pasting in a report without any analysis would not count. We can currently count one component of different data elements now, but now it's looking, the definition was expanded with analysis. So here is a list. It's not an all-inclusive list, but it's pretty extensive. Anytime you review a note and you document that from a unique source, and that definition is something outside your specialty, you would get credit for that. and you would get credit for any unique source. So if you're looking at multiple notes from multiple specialties, you would get credit for each one. The coders will also look for any review of each unique test. So any labs or radiology, you'd get credit for each unique test. If you order unique tests, such as a lab, radiology, you'd get credit for each unique test. If you independently interpret tests where we're not billing a separate code, we would give you data credit for that. If you have to obtain an assessment from an independent historian, which is one of the newer definitions that they've added to this data requirement, where you have to get information from a caregiver or a parent, that would count as well. And then if you would also discuss management or interpretation with an external provider, someone outside of your specialty, you would get credit for that. So the message here, this is the area that the coders are scoring the most in progress note, is to just be clear about all of those tests and documents that you need to review and come up with your plan so that you can get credit for all of those items. And then the third element that the coders are looking at for your decision making is risk. And they added risk of morbidity and mortality of patient management was the expansion of that definition. A couple things that they added to the level of risk is we can count in anything that you include in your documentation for possible management options selected, and those considered but then not selected. So we can include any of that with the level of risk. And we can also include anything as far as risk associated with social determinants of health. And the example that they give here is in my bulleted list where it says the AMA offered this example of if you need to order a prescription, the patient doesn't have any insurance and they choose not to fill it, you still are given the risk credit for ordering a prescription for the patient. And again, these are just some examples here that the coders will be looking for to help with that level of risk complexity, prescriptive drug management, decisions for minor and major surgeries, decision regarding hospitalization and things of that nature. All of that would count towards the level of risk. So we just wanted to show a really simple example of how we take those elements when Artie and Amy are coding and apply it to the medical decision-making versus the time. In this note, a patient had an endoscopic surgery. They're coming in for follow-up. The provider is addressing chronic sinusitis and headaches. We highlighted that with the yellow. So there were 2 chronic illnesses that the provider was addressing during this encounter. Highlighted in blue would be any data. So if a lab was reviewed or ordered or anything like that, that would have been highlighted in blue, and there was no data for this particular visit. And then the risk is low because the patient is using topical nasal spray and nasal irrigations, and there was no other change in the management for this patient at this encounter. So the overall risk when we look at these 3 components, and it's 2 out of the 3, comes up with the level 3 visit. This is a table I just wanted to share with you, and there's a link to this in our PowerPoint we'll share that the AMA created that the coders will be using for coding going forward for 2021 for the new and established patient visits. But on that encounter that I just highlighted in yellow, blue, and green, here's how we apply it to this table. So 2 or more stable chronic illnesses that were addressed in and of itself with this column of problems addressed is a level 4. The data in the middle is minimal or none, is a level 2. And then the risk of testing and treatment is low, so that's a level 3. And so when the coders are looking at your note, they have to look at 2 out of the 3 on this table, and it comes up to a level 3. If it happened to be a new patient, it would have been a 99203 versus a 99213. The other question with these changes has come up about history and exam as well as consultations. So the history and exam is not required for scoring or counting any longer. That requirement has been eliminated. They've come up with the definition or applied the definition of what you feel as the provider of care is medically appropriate. So for all the years I've come to share, 2 to 9 review of systems, a complete review of systems is required, is no longer for the new and established patient visits. It will be based off of your total time on the date of the encounter or medical decision making. The other challenge we have for 2021 is that the consultation guidelines have not changed. So the coders are actually going to be working with 2 sets of guidelines. So consultations, we now still have to use history, exam, decision making, and greater than 50% is spent in counseling. So that is something that will not change, at least for 2021. AMA is looking at other code sets to update, but there is not that change coming for this particular year. And then I also wanted to share the prolonged service code. So they have added a code for prolonged service services that are a longer type visit. You would just put your total number of minutes in the progress note, and then when you reach 15 minutes or more above the highest level 5 or newer established, the coders can begin adding this prolonged service code. So it will only be added when you bill based on time. It can include non-face-to-face and face-to-face minutes, and again, it would go off your minutes. So for a follow-up visit on this table, if it's a 75-minute visit, the coders can code 99215 and have 2 units for the prolonged service code to capture that extra amount of time. I did include just a few FAQs. We have a lot more out on our UConnect hub, but I just wanted to clarify a few things that have come up at some various faculty meetings. One is, can you review a CBC and order a metabolic panel and count towards the data? Can you count both towards the data? And the coders would count both. So the answer is yes, because they're 2 unique tests. Another question related to the data is, can you order an X-ray and review that same X-ray and obtain credit for both towards the data? And the answer would be no. The coders would only count that one time because it's the same billing code. So it's not considered 2 unique tests. And then related to time, can you include rooming time by your ancillary staff in your total time calculation? And the answer is no. The AMA did clarify that with their FAQs that clinical staff or ancillary staff time cannot be added into the time calculation. It does have to be provider time. And do you need to separate face-to-face and non-face-to-face minutes? And the answer is no. We're looking for total number of minutes. And then the last question is related to the resident time. Those rules have not changed, even though CMS has agreed to these changes. We haven't seen an update to the teaching guidelines. So anytime the resident is alone with the patient, we would not be able to count those minutes. It does have to be faculty time. So a couple of recommendations to review and edit your current smart sets and dot phrases. Really, that's meant to help streamline unnecessary documentation, help with that note bloat, to capture all that medical decision making that I walked through that we can count towards your complexity. You can also incorporate some smart tools that we have available in HealthLink for collapsing information for easy readability. We're also recommending that you delete any pre-populated time ranges and replace them with the asterisks. That really is to ensure that we capture all your non-face-to-face and face-to-face minutes on the date of the encounter. Again, determine that your templates are emphasizing your medical decision-making components. Again, we'll keep an eye on the notes, but learn how to document those items that you get credit for the testing and the reviewing of outside documents. Again, this might be a good opportunity just to review your smart sets to see if we can streamline some of that documentation. We want you to know for future state, we do have a hub set up similarly to the telemedicine hub that we have out on UConnect. We do have one for the E&M changes. We're going to have some tools out there such as our coding cards, some FAQs. Birgitta has been working with our E&M task force and the physicians on that to create a skeleton template that we can share with all of you, that if you want to build your templates around that to help emphasize that decision making and the time components, we'll share that with you. That's again being finalized this week and next week. So that should be up on our hub shortly. And then I wanted to give you access to all of that and the links to review that information out on our UConnect page. We've also added an email address should any of you have questions about this information. Brigida and I will facilitate those questions as they come through. In Epic, you can also search in your clinical resources coding section, any E&M 2021, if you type that in, will take you out to our hub page. And then we also wanted to include the AMA guidelines. So that's available here and as well on our hub page. If you like to do a deep dive into why things are occurring or what those definitions are, that is where all that information is at. And you can always reach out to Brigida and myself. We're the leads on answering those questions, but certainly Amy and Artie can help out as well. So with that, we'd like to see if there's questions or what we can answer for you this morning.
Brenda, I have one question. Those
Absolutely.
cards that you're working on, the E&M cards, will you be
Yes.
laminating those and supplying them to providers as, you know, something that they can put in their pockets?
Yes. So we just finalized them this week, so we should be working on that and getting those distributed before the beginning of the year.
I'm going to repeat a question that I asked on the chat box, but the question was essentially, will it no longer be necessary to have past medical history, surgical history, family history, view systems in documentation in order to bill?
That's for billing, that's correct. So as providers of care, now you get to determine what is in the note and what that is relevant to the encounter. I mean, there's a lot of other reasons why all of you document that, but you can streamline it now.
Because I mean, in order to streamline the documentation, so you don't, like you were mentioning, I mean, essentially you have the first 80% of your note is just stuff you put in to pull from the chart so you can bill appropriately, and then the last paragraph or two is what you actually think, and that you can now just put what you think, and then the
Correct.
time that it took.
Correct.
Yeah.
Right, and that is the reason for the change, is because of the 80% unnecessary documentation.
Thank you.
Could someone, Amy or someone, just work through, and we can do it online some other day, like a couple of my notes just to tell me how this affects them? You know, say, here, we'll take an example. This is a new patient. This is a return patient. And, this is where your documentation will be sufficient or insufficient with the new rules. Is that possible?
Yes, it is.
Okay.
And we might reach out to you and Dr. Brooks just to see how we could be best prepared for this.
Yeah, if we just do the practical run through on a couple notes, people will quickly be able to figure out how they must change their documentation. We're going to still treat people the same way, but you're asking us to document differently. And this might be sensible. Billing, it's not necessarily going to make notes readable or understandable to another physician as to what you actually did. That's my concern there.
Yeah. Andrea asked a question about inpatient, but I guess I would ask, as far as inpatient consults, does this affect how those are billed?
It does not. So any inpatient services, the outpatient consultation services, emergency department, none of those guidelines are changing for 2021. But stay tuned. We're hoping the AMA will move forward with other code sets. So it could happen for 2022.
So the message is don't do this as an inpatient, but
correct.
It may
it does
be okay
not
as an outpatient.
Correct.
Yeah. And as a subspecialist, I consider every new patient I see in the clinic to be a consult. Is that incorrect? Should I be calling it something else?
No, I wouldn't change what you're doing, Dr. Dempsey, with the consultation. So keep that the same. We wouldn't want you to change that. And again, Amy and Artie can kind of keep an eye on that and reach out to folks if they see any changes that might affect the billing. Just because we are working with two sets of guidelines, it does make it challenging for the coders.
Thank you.
So again, I know Brigida is gathering the chat questions. Just to be thoughtful of time, if you want, we can take those back, type them up, send them out to you along with the PowerPoint if that works, just to make sure everybody's questions get answered. Would that work?
Thank you. That'd be excellent, because many of us would like to see what other people's questions were. That helps us, things we didn't think of.
Great.
So
I'll
it's
take care of
always, thank you very much. You make a difficult process a little bit more understandable, and we appreciate that.
Well, please reach out if you have questions, you know, in the future before we get started, or even after the first of the year. We'll have that email address up for a while, just to help with the transition. So we're here to help as a resource. And we thank you for your time this morning.
Very good.
Thank you.
Thank you.